Good morning and welcome to the latest installment of Itility Health's webinar series. I am Courtney Gulster, Chief Marketing Officer for Itility Health, and I'm joined today by Chad Frank, our Chief Product Officer and Chief Operating Officer, and Michael Lenzer, our President and Founder. Today we're going to be talking about how you can get medical policy digitization right for AI-driven prior authorization. We have a really great presentation for you today, and as we talk through these slides, we'd love for you to add your questions in the Q&A. I will gather those questions up for a Q&A towards the end of today's session, but please feel free to drop those in as you have them so that you don't forget what the questions are that you'd like to have answered. I will go behind the scenes and Michael and Chad, take it away.
Thank you, Courtney. It's great to have the opportunity to talk to people again today. Chad and I are excited to talk more specifically about how health plans should be working to get medical policy digitization right, especially in the context of the things that are happening with AI-driven prior authorization. Again, I'm Michael Lenzer and excited to talk with you. As we talk through the agenda a little bit, we'll be starting out with just a quick definition of what is medical policy digitization. We've noticed as we talk to various individuals in the industry, there are some questions about what is policy digitization. So we'll talk briefly about that. Then we're going to focus really on how to get medical policy digitization right as it relates to the fidelity to the core human readable policy, ensuring that those FHIR questionnaires are effective and well built, and then how those things get operationalized, and then how does AI come into the picture as it relates to those structured medical policies. Lastly, we'll follow up with some practical considerations that payers can consider. So with that, I'm going to kick it off and talk just a little bit about what is a digitized medical policy. So really, digitizing medical policies ultimately results in four key elements. First of those is having those policies in a system, then ensuring that there are procedure codes and HCPCS codes associated to those policies so they can be operationalized. This is the next element is what a lot of people think about when they think of digitizing policies, and that's the FHIR questionnaire. And then lastly, there is the ability to add CQL code to each question, which is what allows the EHR to automate answers to those questions. So just briefly, in terms of the key challenge with policy management and digitizing policies, is that policies tend to work in a very manual workflow within the health plan traditionally. And the very common approach is that somebody in the health plan writes a medical policy in Microsoft Word. Then there's a process of sharing that policy, tracking changes in the policy, and ultimately sharing that with a group that approves the policy. Once that policy is approved, it needs to be put out in some form for the public to be able to see that policy. And again, today, the way that process oftentimes works is through Word documents and email and PDF documents, and then a website marketing type person deploying documents in a web store on the health plan of the website. This creates a lot of challenges because of so much manual process and unstructured process that makes it hard to track versions of policies and audit the process and really know what's taking place. So the first step in policy digitization is getting those Word documents and into a system that helps to manage that process, and then using that system on an ongoing basis to edit and create new policies. So that policy management system really creates a scenario where the policy is broken down into its key elements that make for an efficient process of creating policies, ensuring that there's a common template or format for the policy, and then also including metadata about that policy in the system, specifically things like the effective date, the end date of a version, procedure codes that are associated to a version of a policy, as well as rule attribution. Does this apply to Medicare, Medicaid, a carve out for a commercial member? And then that policy version includes two key outputs. One of those being a human readable policy that is accessible through the public website of the health plan, but retrieved from this system. And then the other is the FHIR questionnaire, which is the core component of the DTR process. So by having a common system that creates these artifacts, it really drives a tremendous amount of additional efficiency in the process, and again addresses those negatives of the manual process. Another component of digitizing those policies, as I mentioned, is when they are used inside of a policy system, the various elements of the policy are stored in their correct context. So for instance, in this case, you see the multiple tabs that represent the different sections of a policy. Things like the criteria are stored in an area that allows us to create a DTR questionnaire. Coding notes help the health plan to communicate any additional details about coding. Attached documents can be available within a policy, and then a structured definition of what are the required documents associated to a questionnaire that need to be submitted when a provider submits a prior authorization. The questionnaire itself, that is the JSON questionnaire, the entity, the document that is sent to the provider to fill out during the DTR process, references the history of changes with this policy, and then as well the ability to have a policy footer. So all of these are sections of that policy that are now codified in a digital policy system. Another element that gets codified in that system are the procedure codes and HCPCS codes. And you see that these are in a structured format. They're not just buried in a Word document, but they're saved in a system in a way that allows for the particular rule related to that procedure code to be configured. So in this case, for example, this procedure code requires prior auth from January 1st through January 31st. Then there was a rule change to not required from February 1st through July 31st. And then again, prior auth is required again on August 1st. Obviously, this is inappropriate data. It's an odd rule system, but this is a great illustration of how a system allows you to capture and create rules around prior authorizations and procedure codes related to policies. The third element of the policy digitization process, and this is the one that most people think about when they think of policy digitization, is taking that policy rule structure within that policy. This is the elements that say, for instance, any of the following criteria are met, and then this criteria or this criteria, those types of sections in a medical policy that need to be converted into a questionnaire. And that questionnaire might also need to have the context with each section relevant to what procedure codes apply to that section. So the process of creating this FHIR questionnaire, which is what you see on the right, is a really important step in the digitization of a policy. Some of the things that are really important to keep in mind are that there needs to be an easy way for the policy writing team to be able to see when they make a change to the criteria of a policy, how is that change embodied within the FHIR questionnaire? How does that change affect the rules, the ands and ors and the one of the following kinds of rules, as well as how does it show the procedure codes that are relevant to each section. So that's a really important step in the process. Some organizations are using AI to complete this step. And one of the challenges there is that it does create a bit of a risk that when I write a policy on the left side of this, what it shows on the right side or what it shows up inside the FHIR questionnaire might be a little different. Just for context, what happens with this FHIR questionnaire, which is the questionnaire that's on the right side of this page, is that when a provider wants to submit a prior authorization, this questionnaire is sent as a file to the provider's EHR. That EHR then displays this questionnaire in a manner very similar to what you see here. It's using a file format that you can kind of think of like a PDF, form fillable PDF. It's a common file format that when received by the EHR, it knows how to open it up, and the rules that are embodied in this FHIR questionnaire are included in that document, in that file. So the behavior of the questionnaire inside the electronic medical record system is identical to the behavior that you see on the right side of the screen. And this allows for the policy writer to test their conversion of policy from criteria over to a FHIR questionnaire. The last element that oftentimes is thought about when people think about digitizing a policy and getting to a FHIR questionnaire is the ability to convert or to embody a question in what's called CQL. And what you see here is on the left-hand side, I've highlighted a question, and on the right side, you see the actual CQL code that would be received, again, within that same FHIR questionnaire file. And this code on the right is then acted on by the electronic medical record system to essentially answer the question without the provider side of this equation having to go look up the answer and check the box. So this code on the right side allows for the EHR to automate the answers. Now, where we are as an industry is that there's not a lot of maturity yet in terms of electronic medical record systems that can act on the code that's on the right. So most organizations right now are implementing FHIR questionnaires without adding this CQL code because, as you can see, it's a little bit technical. And of course, that means that it's a bigger lift for the payer and a little more work in terms of quality assurance. So for right now, we're seeing payers typically implementing the FHIR questionnaire without this optional CQL data code that will cause the EHR to automatically answer the question. One additional note there is that we are also seeing providers purchasing AI tools that instead of using the code that you see on the right side of the screen, the provider's AI tools can scour the patient's medical record and answer these questions. So there's a bit of an option there for providers. They can either implement an EHR that is really sophisticated at being able to respond to these coded questions, or they can implement an AI tool that automates the answers to the questions. So that's something that we're seeing in the marketplace that's still kind of being settled between payers and providers and providers determining their strategy. So again, to summarize, digitizing a medical policy involves having a system that manages the human readable, the machine readable version. That same system has to allow for the association of procedure codes to particular policies and lines of business. Those policies also need to have a FHIR questionnaire created. And then optionally, they can include CQL code that when received by the EHR automates the answering of questions. And how that works in the workflow of prior authorization, this is just a very high level flow that shows that the provider writes an order in their electronic medical record system. The CRD transaction is sent to a rules system at the payer, in our case, PA Checkpoint, which answers the question, does it require prior auth, and tells the provider system which policy is going to be applicable. It can also allow the provider to see that human readable policy at that point that again comes from the policy management system. Then the provider says, yes, I want to submit a prior auth, in which case the PA policy module sends back that FHIR questionnaire that I showed, and it shows up inside the electronic medical record system. The provider either fills out that questionnaire, the questionnaire is auto-filled because of CQL code, or filled out because of an AI tool that the provider has. Once the provider has answered the questions, they submit that prior auth for an automated decision. And that decision can happen if they've answered all the questions and the rules are built inside of that questionnaire that allows the payer to automate those decisions. All of that information is put into the utilization management system. If it's an approved prior auth, a PA number is sent back to the provider. If it's pended, then a clinical reviewer or some other system kicks in to start helping make the decision. And how that flows in general from the scale of a full implementation is that by giving a good CRD response, is auth required? In many cases, we can avoid providers submitting prior authorizations for things that are not required. In the event providers answer questions within the prior auth, we can see about 85% of prior auths automated using the rules that are based on those questionnaires. And then lastly, those prior auths that get pended for human review, that typically is anywhere from 10 to 15%. And at that point, we're going to want a human to look at that medical policy and compare it to the medical record. In the case where we've built a good FHIR questionnaire, then AI will do its job on the payer side of helping the clinical reviewer compare the policy questionnaire to the medical record and again suggest whether or not it thinks the patient meets each criteria element in that questionnaire. So that's a bit of a primer on prior authorization digitally using the new CMS 0057 APIs and what are the attributes of a digitized policy. So with that, we're going to transition to the core content for today, which is really addressing, how do we ensure that this policy is digitized in a way that supports the workflow we just talked about, and as well, what is the role of AI in this process, and where does that kick in? So with that, I'm going to turn over the presentation to Chad and let you take it from there, Chad.
Thanks, Michael. Yeah, so what Michael had covered a lot when we first started this was looking at some of our screenshots and the perspective we come to market with on how to be thinking about digital medical policies and how they apply in the workflow. And what the next section is going to cover is talking about some of the semantics, some of the objectives we're trying to achieve and payers need to achieve in the market. And the one thing I want us to all agree on today is what we're doing, and that's the start of the circle. And the start of the circle that drives everything around prior auth is we are talking about a structured policy. Everything starts with the policy and the clinical criteria and medical necessity defined within that to drive the rules for prior authorization. You also need to understand applicability, and that might be the difference between a policy for one commercial client may be applied differently and have different rules for a different commercial client or Medicare or Medicaid. So this is about understanding the rule, not just the policy, but the rules within your payer organization of how do I apply that. The ultimate goal is to get to a deterministic decision or an execution, and by that definition, it means we are not leaving this up for interpretation either by a human or by a machine, in this case AI. We are building a system that can do this deterministically across different workflows and different integration points. And also, the other thing we want to achieve, as a industry, is interoperability. So, you as a payer yourselves, how do you have this within your interoperability framework? How does this work within the provider's framework, and larger within the overall community as a whole? And we do that. The outer circle is, now that we understand what we're striving for, the what, how do we do that? Well, we're trying to operationalize the medical policy, the rules, the how do I apply this, the integration points, all within a system that understands the interconnectedness of this data and how to apply it. And really, what we're trying to achieve at the very end of the day is we want prior authorizations that are consistent, and you can go back and audit them for explainability if you need them. And we don't want to do that once or twice. We want to do it at scale. And so if you're a provider that's doing hundreds of thousands of these or more a year, You need to find a way to do this that you're consistently doing the same action with the same input over and over again. So the rest of the slides build upon this, and we will touch back into some of the stuff that Michael did earlier on how we achieve that at Utility Health. All right. So, AI is when used properly is a wonderful tool, and we all use it day to day. Some of us, you're probably using it, even if you don't know you're using it on your phone, on your computers, it shows up everywhere. And it's a wonderful tool that's going to help us all work more efficiently. However, we want to start with the foundation. And when we're talking about prior authorization, the foundation at the top of this slide here is the clinical intent. When the medical teams are writing policies, there's a very specific intent they're trying to define, usually defined as clinical content or medical necessity. And once we start there and we have that definition, how do you take that and put that into a system that understands how to use that and can know how to apply that in different scenarios? And the term we're using today, and we might find a better term in the future, but the one we're using today is fidelity. And for our definition today, fidelity is just meant the level of detail and specificity you have in a policy that allows you to achieve the what, how, and why we just talked about. So, how do you represent the clinical intent, not only in something that somebody can read, but a system can interpret and follow the workflow through? When you have that, what you can get to is being able to say that I, as a payer, whether I'm on the IT house, having to manage this, or the clinical side of the house, or the payer as a whole, I know that I can be able to make deterministic decisions and execute this at scale. When you have that, then it's a matter of, do you have the right tools to put that into your interoperability layers? How do you connect up to, if you're using interop vendors, fire servers, QHENs, your own backend, your utilization management systems, ensuring that wherever this information is housed, you can easily drop that in there. And then this is where the beauty comes in. Once you have that solid foundation, and anywhere you look across the internet, in any industry, the message is the same. AI is wonderful, but it needs to start on top of very solid data that you're removing a lot of the ambiguity and interpretation. And this is where we start to leverage AI once we have this foundation. And this is really the core thing we're trying to talk about this rest of this presentation. So why does this matter now? Or there's three big things that we're seeing happening in our industry and in the world at large, and that is if I'm hoping everyone understands what CMS 0057F is. If you don't, welcome to the party. We're happy to talk to it and educate you about it, but I'm pretty much sure everyone on the call understands it. And that is, we have some pending deadlines for numerous aspects of this, and the one coming up right now that everyone is striving for is January 1st, 2027. So this regulatory guideline is driving a lot of the change we're seeing in the industry. We're also seeing a higher pent-up demand for getting answers faster. Now, you might argue that the CMS 0057 is trying to do that, but CMS 0057 is larger. And we're seeing a lot of things in signals in the industry saying providers want faster answers, payers want to move prior auths through their workflow faster because that helps reduce cost. And the big one is AI. AI is everywhere. And in light of trying to understand, how do I take a structured policy, put it into a deterministic system? If you're looking at this individually as, I have separate policies in a PDF or Word document, I have a spreadsheet in another system that may have a listing of my CPT and HCPCS codes by business unit, and another system that says, well, here are the benefits and eligibility that needs to be applied. And if you have all that in different systems, then that's why people are looking at AI. But we're talking about a better mousetrap. We're talking about, how do we take all this, and it's really changing how the industry looks at this and putting all this into a system that can execute that. And so these are the three big things that are why we put this presentation together. The biggest thing we're seeing is AI adoption is accelerating everywhere, especially in the healthcare industry. There's been a number of things that have come up on different papers, not even written by us, but across the industry, where we're seeing a lot of payers ourselves and through different papers that the payers are starting to accelerate into the use of AI, in this case, specifically for covered decisions. It's positioned as a key lever for helping not only the providers, but the payers reduce cost. A lot of times that's positioned as, reducing workflow or reducing time to find answers. However, we're also seeing an increased scrutiny from different legislative bodies, whether that's at a state level, a federal level, a county level, where I can't think of a time where at least every month something comes up where a state agency or a county agency saying you can't use AI for this, you need to have guardrails for that. And really what we want to do is help people understand that if you're putting some decisions into AI, in not all cases, but a lot of cases, that can go into a black box. So when you're talking about audibility and coming back and trying to make sure you're making consistent decisions, it gets very hard to make that determination. So what's happening in the world today is AI adoption is accelerating faster than a lot of us really know the nuances of how to use it or what that may mean for us as maybe potential negative impacts as we come into it in the future. So the key thing here is if we go back to the basics, and that is we're talking about prior authorization, no matter who you are, what type of prior auth you're doing, there's three things that play into every single prior authorization decision. One is what policy or even cases policies apply. Sometimes if you're going through a particular like an operation and you have multiple procedure codes or hit pick codes, a lot of times those can hit one or more policies with an organization. Then what you have to understand is not only once you understand the policy, but how do I apply that? And a lot of times you might have to start looking into does a benefits coverage change this? Does an exception or carve out based on the plan they bought change it, right? So that's where we're talking about applicability. And then at the very last is how do I interpret clinical criteria and ensure that what's being submitted meets the what we talked about earlier on is the clinical intent, and in this case I'm using the term clinical criteria. How do I did they actually meet that to be able to approve it? So these are the three foundational aspects that when we look at talking about a structured policy and everything we're doing at Itility Health, these are the drivers behind it, knowing that we have this complexity that we have to simplify down into these three areas. And so what determines AI reliability? And if can you jump back a slide, Michael?
Sorry.
You were really fast on the click. You did a double click and didn't even know it. Um, what we're talking about is a term we're using today, and I'd love to get everyone's feedback on whether this term even resonates because we've gone back and forth internally on fidelity even, is policy fidelity. And by that, I'm talking about I understand the very specifics of the clinical intent. I understand the applicability, and that's, not only what procedure codes apply, or as Michael showed you earlier, more than just the procedure code, are there effective dates within those procedure codes and are they changing over time? And then I have to understand, are there benefits and coverage things that determine what this is? Is there a difference in groups or how I'm selling my commercial policies that are different from one group to the next? And all that we're talking about and bundling up in our use of the word policy fidelity. And really, what determines your reliability if you're using artificial intelligence is that foundation of having all that rock solid. So how do we define this? Michael showed this, and I've talked a little bit about this in the previous slides, but that's really of what defines a structured policy? And a structured policy isn't just I have a well-formatted Word document or I have it on a SharePoint folder or system that understands that structure. It's about all the details Michael ran through when he showed you the screenshot. It can be down to what type of medical necessity or clinical criteria is defined. What type of documentation do I have with that? What is the fire questionnaire that goes with that? What are the associated procedure codes and HIPAA codes? How do I apply this in different parts of my business? That's really the stuff we're talking about here of preserving all that clinical intent and then ultimately the decision logic being used. Do I have that consistency to understand that this was the clinical intent and now I know where to apply it and I'm not trying to make interpretations on it, but I can quickly get through that because I have more structure. So whatever you're doing, that clinical intent, it has to survive whatever you're doing, whether you're trying to put AI on top of it, and that's where it gets a little loosey-goosey, or are you putting structure to it that you know that you have solid decisioning throughout your process. Okay, when you have that, what that'll give you is you get consistency. And what I mean by that is if I put the same input to the question, I get the same output every time, right? So there's no interpretation. There's no wondering if even if a user, maybe somebody on your clinical staff looking at prior auths, different people can interpret things differently. In the way the world has existed today, there was some open area for that, right? Even from a human interpretation, and even with AI, are you getting drift on AI's understanding of your medical policy? Are you getting drift on AI trying to interpret what's been submitted to it, right? And that's where that black box goes. And really what you want is that consistent transaction, especially if you're doing this hundreds of thousands of times, you want to be able to trace that for compliance purposes and have that auditability. And then the biggest thing that we keep talking about is repeating that. And we have a situation we'll talk about in a few slides coming up on what does that look like at scale if you're trying to do this 500,000 times a year. So the things you need for interoperability is when we have the deterministic policy, there's three big things we look at, and that is we can enable a very quick integration and tight integration with the new CMS guidelines for CRD, DTR, and PASS. When you have all this, you can do this faster. And then you have the guardrails that you can use for AI. So this, if you're trying to scale your business, it involves having these solid foundation layers for integration and control so you can manage this not only from the business side and decisions, but also from the IT or technical side of the house of how this is fitting into your complete framework. Michael, I know you like this slide, and I don't know if you want to talk. I'm trying to
Sure.
throw you a bone here. If you want to talk, I can talk about it, but I know you love this slide, so I
Yeah,
can let you
yeah.
go if you want.
Thank you. Love to talk through it. So what we're really trying to illustrate here is the idea that when we work to create a effective digitized medical policy and that fidelity with what the policy writer had in mind, showing up all the way through into that FIRE questionnaire, which is that essentially the embodiment of those rules showing up as a questionnaire for a provider. It's really critical that the clinical intent of the human written policy be 100% accurate and match the FIRE questionnaire. And the reason why that is so sensitive is because these policies, typically 400 to 600 medical policies that a health plan might want to use, those policies are used over and over and over again. And what that means is if somehow your accuracy of the FIRE questionnaire, the creation of that FIRE questionnaire in comparison to the original intent of the policy writer, if that questionnaire is not 100% equal to those rules, then you have a risk that in those hundreds of thousands of transactions that are applied to a particular policy, you might have an inappropriate medical intent. So that's why it's so critical that when you create a FIRE questionnaire, that policy writer is able to see the resulting FIRE questionnaire next to and side by side with what their criteria are. That will help ensure that the policy writer has control and knowledge about how that questionnaire is embodied. We've also seen that when a policy writer sees the resulting questionnaire of a policy, that they start to write policies a little differently, and that makes policies more accurate when run through an AI model. For instance, we've seen policies that were written that said the patient needed to have mild to or moderate to severe diabetes. Well, what is moderate to severe diabetes? And when a policy writer sees their clinical criteria embodied in a question, it helps the policy writer to think through, how do I want to write this policy in a way that a system could answer it more effectively? And so again, the point of this slide and this message is that it's really critical that digitized medical policies be extremely accurate when you compare the human readable policy to the FIRE questionnaire because of the frequency and the repetitive use of a particular fire questionnaire. Any additional items you'd like to add to this, Chad?
No, I think that's good. I think it just the biggest ones were the interpretation and interpretation. Although we're talking about AI, if you could jump back to that slide a second, that interpretation is both human as well as AI, right? So it applies in both cases. So whether that's an individual trying to interpret it, or trying to interpret it, not only the clinical intent, and a lot of times you have dedicated individuals within your UM group that are only focused on certain procedures or policies, and so they get fairly good at doing that. But then you also have the interpretation of data being sent back, and all this, the entire CMS and everything we're talking about a deterministic thing is removing interpretation, whether it's at a human level or it's at an AI level.
Oops.
You go to the next slide. So this was we wanted to do is talk about, what do we mean by a medical policy? And in our case, with the utility health system, medical policy has a couple different ways to view it or interpret it. One of them can be, if you're a payer, the medical policies you write or you house yourselves. A medical policy could also be evidence-based clinical guidelines from a vendor like MCG or Interqual. It could be a policy from a delegated vendor you have, like an Evercore, where you might be doing things like I'm outsourcing the decisioning and policies for behavioral health or imaging. So in our definition of a high fidelity medical policy within utility health, we mean all of those cases, or any case where you as a company or a payer are trying to represent or need to understand this is a medical policy I'm using to run my business. How do I use that with an interop? And utility health provides the means to understand the data behind all that. And we have some slides coming up about that show some representation of what, I don't want to say architecture, but how we kind of view our system to talk about that. So in this case, a policy again is your own policy, evidence-based clinical guidelines. It could be a third-party vendor or another vendor I haven't defined yet, but it's your use of a policy. And what we do is when we look at this, we say, okay, as we talked about earlier, when I need to define this, I need to understand, what is the verbiage in the policy? What's the clinical intent, the medical criteria? What is the questionnaire, about this? And I think there was a question that came up, and I'm going to try to answer that question that came up right now. And it said, is policy simply a prior auth rule? Not necessarily. It's very complex. And a policy is all the stuff I'm talking about. It's the associated documentation that goes with it. Are there coding notes you need to understand? What version is it? How does this apply between maybe if you're between a policy that 3M buys versus a policy Best Buy, Target, or Amazon buys from you? So how do you understand those rules and the applicability to it, the association of procedure codes? And even within procedure codes, you have the effective dates that you can have change outside of the effective date of the policy. And then are there any forms that you want somebody to fill out outside of the questionnaire? So it's all those things on a policy that need to come together and understand how they all interact with each other. Because again, a doctor could be submitting, prior auth for 10 procedure codes, and that might hit one procedure code might hit two different policies. And you need to have the ability to understand how that applies. Then once you can understand that, how do I use that? Well, you can use that understanding in your APIs like CMS 0057. Maybe it's an API to your utilization management system. There's another question somebody asked about today on what happens if an EMR doesn't have, or a provider doesn't have a robust EMR. We're seeing a lot of payers continue to utilize portals or provider portals. Well, that same foundation of data we have can drive your provider portals and all these rules behind it. Are there websites you're posting your policies to for providers or for anyone on the internet to go view your policies? And ultimately, how do you make decisions? So when we talk about a high fidelity policy, these are the types of attributes we're talking about. It's not simply a single policy and you're done. It's the definition of the policy, all the attributes and applicability to it, and how that applies to different rules across your business, and how it's then used for your different integration frameworks or your user endpoints. So that's Michael, you disappeared. Oh, there you are. I'm hoping you still had one finger on the mouse or your right arrow button. So when we talk about AI, and again, all this is we're bouncing around a bit here, but all this is to say that AI is a great tool, but we need to start with a really good foundation for it. And in what we have here is a table. I'm not going to go through all these because we'll provide the deck and you can read these as I go through it. But these are some of the top considerations to make on, the value of your AI and how AI is used depends on your ability and willingness to put this definition to a high fidelity medical policy, which is the stuff we're covering, right? And we know the big thing that everyone looks at is, and this is part of what we do, is this deterministic fire questionnaire, right? That is one component of a policy. It's the digitized JSON file in a fire format that is communicated via APIs from you as a payer to the provider that then when they interact with it in their system gets sent back in a different JSON for the past submission that can be interpreted deterministically by the utility health system to make those decisions. And then that can then be integrated with third-party vendors, whether you're using an evidence-based clinical guide like with MCG and InterQual. Because we understand the rules on it, I know if I need to hand that questionnaire response back to MCG and InterQual for you and your teams to go to manage that and do final approvals. I also know if I need to hand it off to a delegated vendor. I understand if I need to hand that off to your internal utilization management teams, right? So all this stuff comes into play, on looking at the value of your AI and where you use it depends on this foundational data. Next slide, Michael. So we're going to talk about the benefits from structured medical policies. So let's talk about when to use AI and where it's best applied. And we used this graphic, a part of it earlier on, and when we look at the structured data of the utility health system, we start with this foundation data of understanding the policy. I understand what procedure codes are associated with it. Maybe you have different programs that run across all of your policies. You might have different groups or carve outs, and that's where I talked about the difference of if you have, like 3M as a client, that you might have the same policy, but the applicability changes based on benefits or procedure code rules for the 3M versus a company like Amazon or even executives at an Amazon. That's all based on the complexity of the payer system and the products they sell to the market. So having that foundation of a rules engine, once you have that, this is where AI really starts to shine. When you have a prior auth submitted back, summarizing the submission of that, it's wonderful, a tool. It can help you get your reviews done faster. If you need to extract data, as Michael mentioned, on the provider side, if you don't have CQL, instead, the next best option of CQL or having somebody fill it in is to have AI.
Whoops. Sorry about that.
Okay, is to have AI assist with that. If you're trying to do, and even outside cases, we're talking to some of our partners out there in the marketplace that they're actually third-party administrators for some companies where if I need workflow guidance and I'm trying to manage the prior auths and I have a team for this payer, they can use that AI as workflow guidance of how to interact with the different teams and the teams for a payer, right? And so this is where the benefits really start to shine in the use of AI. These are the three big things when we look at how we use AI in the utility health system, but they apply universally everywhere, right? It's great at data extraction, it's great at summarization, and it's great at reviewer assistance. It's not great at if you want to rely where you need deterministic decisioning, leaving that open for interpretation or drift. And we have some white papers out there we wrote that talks about some of these concepts. And so we'll move on to the next slide because I know we have a few things left we want to cover, Michael. And I don't know if you wanted to take over from here. Or you want me to keep going?
No, keep going, Chad. Thank you.
Yeah, no worries. All right. So some practical things to consider as you're going through this, right? That when you look at, we use the term, again, high fidelity medical policy, and that goes back to a few slides we had in the questions on what do you mean by medical policy? Is it a set of rules? Is it just text in a Word document? Well, no, it's a lot more than that. It's all the things we talked about with the versioning, the association of procedure codes, the applicability of your business rules, the fire JSON questionnaires, the forms, the documentation. And when you have that, you can reduce rework or friction. Without that, what we're seeing a lot is there's back and forth communication with the providers, there's back and forth communication internally. One of the big things is you want consistent, traceable decisions. If you're leaving this open for human or AI interpretation, you're going to need a lot of stronger governance. You're right. You're going to have to put a lot of controls in there to manage that. It's not just throwing it out there and hoping everything works. And really what this gives you is scalability. And that's what we talked about, whether you're doing 100,000 prior auths a year, 500,000 or a million plus. The more you have the definition around this and the deterministic decisioning, the better everything scales. So to summarize this, what this means is our guidance and what we're seeing, the best in class payers out there doing, and the people we're working with, they're trying to preserve the clinical intent of the policy and really trying to understand how to utilize that now, not just for human interaction, but also system interaction and how that applies across all the different workflows, right? We're trying to build, you need to be building this. How do I take this Word document or PDF document or wherever your policy is stored? How do you turn that into something a machine can use consistently? And then really, how do you apply AI on top of all this? And that's really what we've been talking about today is at the end of the day, these are the three big things that we end up getting into discussions with our payers when we're helping set them up for success. So my last thing I would say on this slide is the last footer in all of our slides. And the one thing, if you can remember, is if you have a deterministic policy, which is what we've been discussing all day today, you can enable your AI at scale.
And I'd love to cover this
Sure.
topic, Chad. So
Yeah.
when we get asked, what is Itility Health all about, and what are we focused on? I think our key focus as a company is to drive that automation at scale by creating a prior auth intelligence layer, a solution and a suite of products that help to codify rules, assist the customer, the payer in managing that content, ensuring that content is accurate, doing that efficiently, and then also bringing that data to life, making it transparent for both human readable systems, publishing policies out on public websites, allowing those policies and rules to drive decisions in a prior auth interoperability world, and then ultimately then using that data to automate the decision making. And as we've talked about, if the FHIR questionnaire is written well and the provider answers the questions, we can make accurate decisions on a repetitive basis at scale in real time. Then, in the event those questions haven't all been answered effectively, the medical record data can be used to assist using AI to help make those decisions when a more human interpretive process needs to come into play. So ultimately, the question we'd like to ask the participants in this call is, as an organization, do you have a prior auth intelligence layer? Do you have those policy rules? Do you have those prior authorization rules in a system that can be easily accessed and leveraged for CMS 0057? And that is the foundation of an automated process and of an effective AI use of prior authorization. And when we think about this from the Itility Health product perspective, our products sit on top of that prior authorization intelligence layer. PA Checkpoint is the tool used to configure and retrieve information around whether or not a prior authorization is needed. PA Policy, as we talked about, is the tool to digitize all of that policy information, manage the workflow of creating and managing policies. Prior auth routing is where we know about downstream vendors and delegated vendors and other clinical sources of clinical data. PA Decision is our tool that looks at the answers to questions and makes a decision. PA Assist is our AI tool that leverages, again, all of the data in the intelligence layer and compares that to the medical record and assists the human in making a decision.
Michael?
Yep.
Could I add one thing on here? Because I found it helpful in talking to different people about helping to understand throw in a new term we haven't used, the utility health difference. And that is, one of the things that we get into when we get into implementations, and we're doing a number of them across the industry, is helping somebody, maybe if they weren't part of the buying process, understand what we do. And the core component is this foundation layer that we found to be the biggest thing to kind of get people in line with what we do. And that is, today you have disparate systems of information. A lot of times we see your policies in SharePoint on whether it's a PDF or Word document on an HTML site somewhere. Your procedure code may have a list in one or more spreadsheets. It can even be in your claim system utilization management. We see different systems of data of how am I working with my third party vendors or delegated vendors like Evercores of the world. And then any other data, your benefits rule, anything that applies to how do you make decisions. And really our difference is that foundational layer. We understand all that. And either we understand where it lives and understand the metadata, how to use it, or we house it in our system. And that core foundational layer is what Michael's been talking about, is all that information is not disparate anymore. We either understand it or we house it, and then you can manage it within our system. And then on top of that is how we understand the applicability and rules and intelligence, and then the tools we have on top to make that. And that's been kind of a key differentiator, helping people get up to speed on the utility health difference of really what makes us different out there.
Thank you, Chad. So with that, we'll turn it over to Courtney, and she can help us work through the questions that have been asked. We'd be happy to answer your questions.
A few have been answered throughout this process, but just adding to that here. First question, does your tool support both procedures and drugs that require prior auth?
The utility health tool sets do support medical procedures and medications, predominantly specialty medications. We do not currently address things like formulary and those types of topics that are more typically in the retail pharma area. But for example, for 0062, our product does support those specialty pharma drugs that need to be a part of a CMS implementation.
Thank you. We also received two questions that are similar, but I'm going to read them both so that you can answer both of them at the same time because there's definitely some overlap here. Question one, with turning policies into a FHIR-enabled questionnaire, how do you ensure for response fidelity without clinical data? And question two, what are the steps needed to turn a high fidelity policy into a DHR questionnaire? Is it as simple as adding into ITR, then using the Smart Questionnaire button? Are there additional steps or templates you recommend building from?
Two really good questions. So the first question about how do we ensure that we have response fidelity in the event a provider hasn't submitted the clinical data? Um, this is a really important question because as people think about having a provider answer questions and providing approvals based upon those answers to questions, there are a couple of risk factors. One is that the provider is not telling the truth, which of course is fraud, but in many cases we might anticipate providers game the system in their terminology, which is a really bad practice, of course. But how does the payer ensure that they know if those answers are consistent with actual clinical data? What we have done is our customers' FHIR questionnaires typically do require the submission of clinical data along with the answers to the questions. By capturing that clinical data, you are still able to then, after the fact, run an audit process where you can selectively sample provider submissions and compare their answers to the data that was included in the attachment. And that is a perfect use case for, again, AI as a tool that can run through that comparison rather quickly and give you hints as you work through it at a more typical audit process. So that's the critical component of this, and that is, again, to ensure that the documents are submitted and then provide the ability to compare those documents to the medical policy. The next question about what are the actual steps of creating a DTR questionnaire? That's a really good question. We showed you a slide that showed on the left side the human readable medical policy and the questionnaire. There's actually an interim step in our system where we show the policy writer how the system has interpreted their their policy criteria as a technology resource. So, for instance, we highlight if something has an and an or together uh, below it. So we make sure that the policy writer has complete control and sees those rules as a part of the questionnaire itself. Then, when the policy writer hits the button that says create a smart questionnaire, the technology, our system is using that knowledge that we have around the technical interpretation of the rules when we create the fire questionnaire. So there are a couple of steps there, and that's very different from what we've seen. In some cases, there are organizations that have talked about applying AI, which essentially says we're going to take the policy, the human readable policy on the left side, and create a fire questionnaire using AI. The challenge with using AI in that step is oftentimes AI changes the words, it changes the order of questions, it changes the questions. And as a policy writer, I want complete control in ensuring that the policy that I've written is converted into a fire questionnaire in a way that matches my intent.
Michael, can I add something to that?
Yes.
I think one of the biggest differentiators we have too is that in the utility health system, we are not separating the creation of a fire questionnaire with a policy. It's one and the same. We view that as one and the same things in our system. And if you don't have a system that allows the editor to be able to do that in human form, then that's where not only do you have drift, but you have a separation on the source of truth of the medical policy in what the clinician wrote as medical intent and a digitized questionnaire. The way we built our system is if you're editing the questionnaire, you're also editing the output of the policy or vice versa. So you see that one and the same. You never have that separation that you have to worry about. And that's one of the things we talk about consistency and traceability is you're doing one and the same thing within our system.
We have one last question that I do think is important for us to cover. I know we're coming up on time, but I joined late, so I may have missed this part. How does the system support changes to medical policies and automate questionnaire updates, either for a new plan year or compliance changes needed mid-year?
Great question. One of the things that having a medical policy system does for you is the what we call metadata around a policy is in the database along with the elements of that policy. Some of that metadata include things like when is the next review date for this policy? When was this policy last reviewed? So that helps to ensure not that the health plan has a structured process of reviewing medical policies on a timely basis. When they do want to edit a medical policy, that policy is cloned into a new version of a policy, and then the editor can adjust that policy as required, and they can change its status to draft or in review or ready for committee review so that we can help to guide that policy through the various stages of the workflow. Once that policy has been finalized as a status in our system that says published, then the effective date of that policy becomes active. So, for instance, I can publish a policy, a new policy, but have its effective date be 2 months into the future. So it allows for the health plan to create new policies and not have to move them into a released system on the day they become active. The last point in that question was how do we ensure that when they're making those changes, what is that process to ensure that the fire questionnaire changes along with any other clinical intent and elements of the policy? And I showed a slide that showed the clinical criteria on the left side of the screen and the fire questionnaire on the right side. And I mentioned that there's a little bit of an interim step from when I create that human readable criteria to creating the fire questionnaire. In terms of answering that question, if somebody edits the clinical criteria, that system would then show them how those edits affect the technical logic that's going to be embodied in the fire questionnaire. And one of the steps that is expected at that stage is that they do create that fire questionnaire at that last step. So essentially, we walk them through a workflow that ensures that if they change the criteria, we change the fire questionnaire.
Thank you both for sharing so much information today. I know we went just a couple of minutes over, but I hope that was extra informative for us to cover that last question. If you have questions, you can reach out to our team. Anna is the coordinator for this webinar, so any of your responses will go directly to her, and she can circulate it to the best person on our team to follow up with you. If you'd like to schedule a demo to learn more, we'd love to speak with you, and we'll follow up with everyone with a recording of this session in the next couple of days. Thank you so much, and I hope you have a great day.
Thank you.